I'm Sasha Perl at the University of Pennsylvania, and I've been asked to answer the question, what are the future prospects for FLT3 mutated AML? I can break this into three groups. There are patients who are treated intensively from new diagnosis of AML who have a FLT3 mutation, patients who are not candidates for intensive chemotherapy, and then post-transplant patients. To start with the first group in terms of newly diagnosed AML, eligible for intensive therapy, being treated with curative intent, and have a FLT3 mutation. And I'm going to focus this mostly on patients who have FLT3 ITD mutation because I think we have the most data there. At present, the standard therapy is to give intensive chemotherapy plus a FLT3 inhibitor based on data from the RATIFY study that studied midostaurin versus placebo and showed superior overall survival for patients treated on the midostaurin arm. And one of the reasons this study was successful was because so many patients went on to transplant. And interestingly enough, patients who received midostaurin and then went to transplant in first remission actually had superior survival compared to patients on the placebo arm transplanted in first remission, a topic I'll come back to later. Right now, the big question in the field is midostaurin is not the only FLT3 inhibitor, and what should be the FLT3 inhibitor given from the start of induction and through chemotherapy to patients treated intensively. And this is being studied in a number of randomized trials, and we don't have the data yet. So for future prospects, we hope to hear actually relatively soon with the newer FLT3 inhibitors that are either already approved in different settings, such as sorafenib, gilteritinib, and in Japan, quizartinib. Are any of the newer drugs better than frontline midostaurin? And at least for gilteritinib, crenolanib, and quizartinib, we hope to have data from studies very soon that will start answering these kinds of questions. We have a randomized study of quizartinib versus placebo as frontline therapy with intensive chemotherapy that will read out in the near future, likely within this year. And studies of either crenolanib versus midostaurin or gilteritinib versus midostaurin as the FLT3 inhibitor added to intensive therapy are ongoing. And I encourage participation in those trials. And that hopefully will answer the question in terms of frontline TKI use, what's the best drug in this setting? The second question has to do with patients ineligible for intensive chemotherapy. And we're seeing interesting data adding FLT3 inhibitors to existing low intensity therapy. At present, there's not sufficient data to recommend adding a FLT3 inhibitor to azacitidine, but we hope to hear more about why that's the case. There's a phase 3 trial called LACEWING that added gilteritinib to azacitidine compared to azacitidine alone in newly diagnosed patients with FLT3 mutated AML who are not intensive chemotherapy candidates. A lot of questions about that study. It's an open label study. There was the possibility for crossover in the control arm. So while that study was halted because it was not predicted to reach its primary endpoint of overall survival, there's still a lot we need to see by reviewing those data. At present, I'm treating my patients with venetoclax and azacitidine, and then switching to gilteritinib if they're relapsed or refractory, as is the labels for both of those approaches. Lastly, post-transplant maintenance. I am currently giving patients in first remission gilteritinib or sorafenib as post-transplant maintenance based on both feasibility data and randomized data for sorafenib to say that there is better protection from relapse in that setting. But whether this is the right approach in patients treated with TKIs from the get-go is unclear based on the data I just mentioned from RATIFY, where patients treated with midostaurin and intensive chemotherapy had better survival than patients who did not receive a TKI. And we hope that the study looking at gilteritinib post-transplant as maintenance versus placebo, which is completely enrolled but not read out yet, will definitively answer this question. That study is called MORPHO, and look for that result in the coming year.